Hello, everyone, and welcome to another edition of the Cameroon Town Hall for healthcare professionals. I hope you're well. I hope your families are well. I hope your year is going on well so far. It's just interesting how much the year has advanced and how fast time has gone us by. We are almost midway into the year, and this is exciting because it's been a positive year so far for me, and I hope it has been for everyone. I hope all your goals that you had set for this year are being checked. And talking about goals, what more could we be talking about in the, in the middle of 2022, apart from our primary goal, which is combating a pandemic that has paralyzed us for the past 2 years. We can't get tired of talking about COVID-19. Today's session is going to be an exciting one. We have two people who will be giving us firsthand experience of what it means, like conducting disease surveillance and monitoring and all of that, especially within the context of a pandemic, and what we have learned so far so as to carry it forward to the next generation. But before we talk about our main topic of today, I'm excited to welcome you all and to welcome our moderators into this session. I'm going to be moderating this session with Christelle Juego. Bonjour, Christelle.
Bonjour Alison, hello everyone. Bienvenue à cette édition, à cette 50e, je crois, session de Cameroon Town Hall. C'est un plaisir pour nous de vous recevoir encore aujourd'hui. Et surtout pendant cette semaine, nous fêtons aussi la fête de l'unité, je crois la 50e édition aussi. C'est un honneur aussi de partager l'expérience dans la prise en charge et la préparation pour les épidémies avec nos deux confrères qui nous ont permis aujourd'hui de partager leur expérience avec chacun de nous. Merci encore. À toi, Alison.
Merci, Christelle. For those of you joining us for the first time, this is a Cameroon Town Hall for healthcare professionals. It holds every fortnight, and usually we have a couple of co-moderators in the house. Elvis will be joining us later, for those wondering where the Gwei himself is. And we have Therese, who might be joining us later as well. And our own very Bryan is going to be leading today's session. Before we present, we give you an idea of who our main panelists and presenters for today are. I would hand it over to the chairman of the Cameroon Town Hall to give us a welcome address and to present the COVID-19 updates that he has for us today. Hi, Dr. Muno.
Okay, thank you, Alison. Thank you very much. And thank you, Christelle. I just don't know how you guys find time every 2 weeks to be here, and the amount of sacrifice all the moderators are making, Bryan and Elvis and everyone else who's involved in this is amazing. I just want to thank you all and say you guys are really our heroes. Trying to change healthcare system in Cameroon, trying to get the diaspora understand what is going on in Cameroon, trying to also get our Cameroon brothers understand how the diasporans work and what we can learn from the diaspora. I think it's a wonderful forum, and without you guys, we will not be able to be here every fortnight to talk about different healthcare issues in Africa and in Cameroon in particular. So I'm just going to rush over to the topic. I'm very pleased today to have two bright minds who are going to talk to us about pandemic preparedness. And before we get there, I will just want to give an update about COVID. So right now, we've been in the world of COVID for almost 3 years. And we've gone from the original strain to alpha, beta. We're just cracking all the Greek alphabets. We're at Omicron. I'm still waiting for when we're going to get to Pi. But we know this pandemic is going nowhere. It's fast becoming a disease that's going to stay with us. And right now, we are actually having new subvariants. There is the BA2.121, which is in the US predominantly, and in South Africa and other European countries, we have the BA4 and 5. So the question is, I'm here in the US, this is just a cartoon representation. So do you still think this is not worse than the flu? So it's just, we've had 1 million people have died in the US. It's kind of pathetic that we could actually, in this same age, see 1 million people die of a disease that we could prevent, and that we could use multiple strategies in order to prevent people from dying. Now we're still just like soothsayers trying to figure out what next, what to do, looking into the wall and actually thinking if others have a bit behind their mask. So what we can see is that we're having variants and it's not going to stop anytime soon. Each of them are coming with different characteristics that we need to better understand and get a way forward for the pandemic. We do know that the amount of patients who are coming up with BA2 are reducing. BA1 is actually almost totally gone. We're having BA4 and BA5. In the US, we're having 2.121. So there are multiple reasons why we're still having a lot of new variants, and we need the world to actually get a committed strategy in order to end this. We need vaccine equity. We also need to protect our immunodepressed. We need to look for a way to take care of animals and reservoirs for this virus. We also need to take care of co-infections. Now, what we are seeing, I'm not trying to encourage this, but we're knowing that this is going to be a disease. It's finally going to end up be like the flu, not necessarily because we would have a lot of people who are vaccinated, both herd immunity vaccines and those who have had vaccines themselves. And we're seeing that a lot of people are getting reinfected, but they're not actually getting severe disease, which is a good thing. And we're trying to better understand this, those in the CDC, the NIH, those in the European Union, and also African citizens. Now we are having a surge in New York City. We're not having a surge in the number of deaths, but we're seeing that the number of people who are vaccinated, who are getting reinfected are more than usual. So looking at just last month, you could see here, the green was where you had low infection, and looking at this month, you can see exactly what is happening in the US. There's been a drastic change. We do have in New York City, the number of cases are rising. We do have a new way of surveying. By surveying the sewage system, I think it's a brilliant way of surveying the disease, and we're able to pick up areas where we're having new disease occurring. Just based on this, you could see here in Massachusetts, we can see exactly the number of different counties and number of cases that are increasing in different counties over time. This is just telling you, this is just up to yesterday, showing you exactly the surge in several areas which we can pick up. Now, we do know that the number of people coming to the hospital, because we're not testing everyone right now, we're not encouraging people to come test. And maybe epidemiologically it's not even advantageous for people, but now how do we survey the number of people who are infected compared to the number of people who are getting sick? We do know the true number is different from the number of case reports. And here we're seeing that because almost everyone is getting vaccinated, you tend to have a skew in the report that the vaccinated people now start getting sick and also vaccinated, but the number of deaths and lethality has dropped drastically because of vaccines. So vaccines still do work, and it's important for us to know that. Now, do we still need to put on masks? This is going to be a debate forever, and I think we should, because it has actually reduced the number of other respiratory infections, especially in places, but this is about comfort of others depending on where you are in closed areas. Now, looking at lethality for COVID, in countries where you did have a lot of COVID cases like the US, at a certain point, the number of people who died from COVID became the #1 killer. As I've told you, 1 million people have died from COVID from the US. In the world, it's about 6 million. I'm going to present that statistic. Children also do get sick from COVID. And it's my opinion that these children, when it's FDA approved and also approved by the European Union, then these children need to get vaccinated also. Here is the state of the disease worldwide and the countries that you still have active disease. Africa is pretty almost free of COVID at the moment, but we need to keep our guards up. And I do actually want to congratulate Africa and hope that we keep this way and we get ourselves vaccinated. This is the state in the US. You're seeing that the BA2.121 is actually replacing the BA2 and becoming the predominant variant because of its virulence. And here you're seeing just the similar graph really talking about the number of cases. We can see from this, for those who are interested in the future to see the characteristics of these different subvariants, how they behave compared to the original Omicron. And what we know is that resistance to monoclonal antibodies is very high. I would use this presentation today to talk a lot more about treatment for those who are back home in Africa, so that if you get cases and if there is sometime a surge, you will know exactly what is approved, what is available, and what you can get. So here is just a phylogenetic tree showing you Omicron and the different subtypes and what is happening, the differentiation between Omicron BA2 and BA1 and the different subgroups that are occurring. These are the several mutations across lineages that those who are doing genetic surveillance are actually looking at in order to differentiate the different viruses. Here you can see in South Africa where they have done, GSET has done a wonderful They have a wonderful surveillance going on. South Africa is one of the countries picking up the variants even above all European and American countries. So I want to applaud them for the work they're doing concerning COVID. And each time we think we're reaching the finishing line, but I think I just want to conclude today, we'll never reach. COVID is coming here to stay with us. We're not going to end COVID, but we can actually prevent ourselves and make COVID a regular disease by getting ourselves vaccinated, getting people to a point of herd immunity by vaccinating them and getting the right schedule. So we need everyone on board, the scientists, everyone needs to continue work on how we're going to get this stabilized and people not die from it. I've always said the switch sandwich model is really what we need. We need all these different methods in order for us to fight the pandemic and learn from it. So these are the different methods we have talked about over time. I'm not going to insist on them. We're at the end of the road for masks, but I think it should not be, because those who have experienced pandemics in the hospital like myself can tell you exactly that masks do work, and they do work very well. I always give a story. Prior to wearing masks in my hospital, you could look at doctors. There were more than 20 doctors going out on COVID every week. And after wearing masks, we had just about 2 or 3 doctors throughout the main pandemic that killed a lot of people in the US. Now you can see the number of cases are almost 500 million, but this is an underestimation, because when you look at survey prevalence in the community, you get to see that there are areas where know that almost 3 or 4 billion people have already had COVID. And we also do know that we have had about 6.2 million deaths from COVID. The US alone has had 1 million out of those deaths. So this is crazy. And we have also vaccinated almost 12 billion doses of vaccines have been given. There is no vaccine that has been given like this. So in case of those who are talking about side effects, we do know the side effects. You cannot talk about not knowing the side effects after giving 12 billion doses of a vaccine. So here we do have the same statistics. Cameroon, the number of cases have not increased since last month. I think the number of cases have stayed the same. Cameroon is kind of almost COVID-free. I need those who are in the field to tell us more. I think Dr. Karl is going to talk to us about that. In the US, we've still had some few cases, but not as dramatic as usual, but we're having cases, surges in cases right now. Yeah, we do know that there have been an improvement in vaccine technology, and we're hoping to get new vaccines. We're getting new diseases emerging and becoming predominant, so we do know we must have learned something out of COVID. We did get a COVID vaccine in 1 year. So 12.2 million shots have been given worldwide. Cameroon has given just about 1.8 million shots of COVID. And please, you have to encourage your loved ones to take them while they're free. We still have vaccine problems with equity in vaccination, even availability. And when we even have them, we allow them to get expired because we are not interested in getting it. So something needs to be done in low-income countries in order to help us. We don't have vaccines, and when we have them, we don't take them. So these are the different vaccines we take, and we have also been availability of vaccines. We have had the cheapest vaccines in place, the Oxford AstraZeneca, which is efficacy is not as good as the others. So this just shows you that vaccines still work when you look at the community as a whole. Those who have had boosters do turn out to have severe disease very less frequently. And this is really to encourage everyone. Once you take a 3-dose vaccine, and during the time, your chances of actually getting COVID and getting severe COVID reduces by 90%. Here are studies to back this statement up. And also the 4th dose, which has been done in multiple countries, is now standard of care in the US for those who are above 60, in Europe, and in Israel for everyone. So they are seeing some advantages. There's reduction by 76% compared to actually the 3rd dose. So it's important to know this data so that when you talk to people, you're able to quote them, the data. Here is just data showing you for 2nd dose and boosters, how they do actually prevent people from dying. And it reduces the risk of dying from COVID 14 times. You can imagine that just by getting the vaccine. So why don't you get it? And this is the same data stratifying per population. So when are we going to get the next variant? Is it going to make a lot of a difference? Do we need a variant-specific vaccine? I don't think we need a variant-specific vaccine, but it's a debate, and we're going to get, CDC is working on that. And are we going to skip pi and go to rho because pi is so common, or we'll go to sigma? That's something to really think about. Now, the world reacted to Omicron in a very catastrophic way. I hope they don't get to react to the next variant in the same way and shut people down and tend to stigmatize countries. Is Africa working on its cold chain in order to preserve this vaccine? Have we learned anything out of this? I hope we have. I'm not there. Those who are in the field will be able to answer. Where are we in the process of getting our dream vaccine? I know we have several groups, pharmaceuticals and Waterreed, they're working on a pan vaccine. I don't know exactly where they are. They were almost at phase 2 clinical trials. We need to get updates from them. Now, I would insist more on therapeutics for some few minutes. So we do know that there's therapeutics out there. There is molnupiravir, there is Plascovic, which is the Nematrelvir, which is combined with ritonavir. And we know that there's monoclonal antibodies, and remdesivir actually has been approved in the mild disease, and it works better in mild disease. We do have interleukin-6. I'm going to present the data very fast. For those who want to have this data, I can share the slides with you. So we do know that corticosteroids do work, and here is the equivalent you can use. Those who are practically treating patients is not complicated. You can either use DEXA, hydrocortisone, solumedrol, or methylprednisone and prednisone at different doses with equivalent doses in order for patients who have severe disease, and we do have this in Africa. Now for our interleukin-6, tocilizumab is a very expensive medication. We use it in oncology a lot for those who have cytokine storm. And this may not be available in every country back home in Africa. We do have baricitinib, which is a JAK2 inhibitor. It's available. We use it for rheumatological problems. And actually, we can have this available back home. So we can use it in patients who have inflammatory markers are high and you have started them on steroids already. Now we do have Plascovic, which it's available, not in other third world countries, but I think WHO has to do something about it so that those who are vulnerable can have it. Here is a clinical trial for this medication. It reduces mortality by almost 90%. And here are the two major drugs, Plascovic and molnupiravir. Molnupiravir is actually not as effective as Plascovic. Here is a mechanism of action for those who want to know about it. And molnupiravir actually, it has, for WHO, has a high recommendation in place in the absence of Plascovic. Now, sotorvimab is monoclonal antibodies. I don't think we need to stress on that. In areas where there is no resistance, we can use that. Remdesivir has been available, and I think with the availability of these other drugs, the price is going to go down. It actually does reduce patients from getting severe disease. And we do see other monoclonal antibodies. There is Evershield, which is used a lot in patients who cannot get vaccinations, those who have cancers and other things, and who have those who have diffuse large B-cell lymphoma, leukemias, and those who are receiving monoclonal antibodies. You can get this and last for 6 months. Ivermectin doesn't work. WHO doesn't recommend it. Your convalescent plasma does not. Hydroxyurea does not. And hydroxychloroquine, sorry, does not. And I presented data on this several times. Anti-HIV medications do not. So here's a summary of the different strategies we use. Antivirals, we do have 2 antivirals which have actually worked for COVID. And I think this year is going to be the year of medications for COVID. We do have 3, sorry, with remdesivir, which is an antiviral. We do have immune modulators such as corticosteroids, interleukin-6, and JAK2 inhibitors, and colchicine also in low-income countries. We have that available. There is data, but it's not FDA approved. For more of adjuvant drugs, there is nothing really available that did work. Vitamin C, vitamin D, all of this did not really work. So what I want to say is that the most important trial for everyone to remember was a recovery trial. So people need to start thinking the way the UK government taught. And this trial alone gave us several medications, led to dexamethasone, toci, bari, monoclonal antibodies, colchicine, dexamethasone. A single trial led to this, and multiple countries could not even give us this. So let's go back to the Swiss cheese model and be able to prevent ourselves from getting diseases. Now I'm gonna just teaser. This is what disease is this. So if someone knows, they should tell me. But this is the monkeypox, and we're hearing about it. And today our topic Really, we thought this was only in Africa. There's a global, we're living in a global world. People travel now very fast. Diseases can move around. And here is the statistics that we have. These are the number of cases we have as of yesterday. I got this from Bryan. We have 142 cases in the US, Canada, United Kingdom, Spain, Portugal, Italy, Sweden, Germany, Netherlands, France, Belgium, and Australia. Prior to this, you had monkeypox in Cameroon, you had it in the Democratic Republic of Congo, Gabon. Those were all around the equatorial areas where they interact a lot with monkeys, but you see this is something. So I just want to thank you all for coming, and I wish that we have a wonderful discussion today. So over to you guys. Let me stop sharing my screen.
Thank you, Dr. Muno. Thanks for these updates. We are always looking forward to them because then we don't have to go read the COVID literature. It's really dynamic and it's changing very fast. But these updates usually are a really like nice and succinct way of putting together what's recent in the world of COVID. So thank you for taking the time to put together these summaries for us. Just a quick question, which I got in the week, and I was like, okay, I'm just not sure what to tell this person. And the question was, is there a possibility of us finding ourselves with a variant of a virus that combines the monkeypox and the COVID-19? And I'm thinking, you know.
I don't think so. Why? Because just my little virology, I'm going to tell you, I'm not an expert in virology, but I did do a lot of. So the monkeypox viruses are actually DNA viruses. And at the end, if Bryan has something to add, I think pox viruses are DNA viruses, and they are one of the largest viruses. They're very similar to bacteria, more similar. So huge DNA material, and they have circular DNA. So it's going to really be impossible for that to happen with your COVID virus, which is more of, and they are double-stranded, so they are completely different viruses, so they cannot really, they cannot combine together. It's impossible, really.
Okay.
Virology 101 is not going to be possible. So, but pox itself, now monkeypox can combine with chickenpox, and combine, most likely they can share a lot of ancestral. That's why cowpox was used. If you know the vaccinia, it's actually cowpox being used to cure smallpox. So in order for you to treat smallpox, you gave them cowpox. That was actually how Jenner started vaccination. Mm-hmm. He realized that once you infect children with cowpox, they do not develop smallpox. So really, that's really the strategy. That's the oldest vaccine we have, and it still works to today. They have changed the way it's done, but that was the traditional way it was done. He just got Karl and then did that. Okay, let me allow the others to present. Thank you.
Okay, thank you, Doc. So we're going to dive into the topic of today, and I'm excited because not only do we have our presenters here with us, I'm seeing some of our senior epidemiologists from the epicenter back home who've joined today's call. So I'm looking forward to a really, really engaging session. And the topic of today is pandemic preparedness, experiences and lessons learned. We find ourselves at the crossroad of, you know, a pandemic and other little epidemics here and there. And it's, I think, time to pause and reassess what's going on and what we've learned so far, and hopefully even keep documented evidence for the future, because the one thing is sure, this is not the last pandemic. So what lessons have we learned so far to carry to the next generation? And we have two amazing people who are going to be leading today's session. We have Dr. Bryan Tegomoh and we have Dr. Karl. So I'm going to go ahead and introduce Dr. Bryan Tegomoh, who is really not a stranger in the house. And Christelle would introduce Dr. Karl for us. Bryan, as he likes us to call him, because he says, Alison, I want you to keep it simple, even though I don't know why he wants us to keep it simple, but Bryan is a clinician scientist. So he did his medical studies at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé 1 in Yaoundé. And he went forward to obtain an MPH in infectious diseases and vaccinology at the University of California, Berkeley. He currently works as a medical epidemiologist. So his work entails quite a lot of clinical work at times, and more recently, public health disease surveillance. And I'm going to hand over to Christelle to introduce our second panelist.
Thank you, Alison. Thank you for giving me the floor. So I have the pleasure to introduce our second panelist of today, Dr. Fai. I think he's also simple as Bryan. He kept it very small, the, the presentation, but Dr. Fai is a medical doctor as well, trained in the University of Yaoundé 1, that is in Cameroon. So he has been working in several settings, especially back home here in Cameroon, be it in Bali, Minta, Widikum, Oku, where he successfully lead some very high positions. And later on, he went to the Nagasaki University in Japan, where he obtained a master's degree in tropical medicine and a diploma in tropical medicine and hygiene. After this degree, he joined Epicentre, the research and epidemiology branch of Médecins Sans Frontières in Yaoundé, here in Yaoundé, and he has been involved in several non-transmissible diseases like borreliosis, ulcers, snake bites, and most recently COVID-19 pandemic research project. He also acts as technical consultant for the Public Health Emergency Operations Center of Cameroon, especially to the Operation and Operational Research Department. Dr. Fai has a great interest in global health management and leadership in advancing international development, especially in Africa. So here is a brief summary of our second panelist, and we are very proud of having both of you this evening for this presentation. Over to you, Alison.
Thank you, Christelle. And I'm going to now hand over to Bryan to take it away.
Yeah, thanks a lot, Alison, and really thanks a lot for that really gracious introduction. Can you see my screen? Awesome. So yeah, thanks. I think it's really very timely, and we're just really coming out of, still going through a pandemic, and most recently we are hearing about new outbreaks of monkeypox virus as well. So just to relate to the questions you asked about recombinant events with the monkeypox, so it's really very much aligns with some of the things we probably will have to discuss about today. How do we set up these kinds of surveillance mechanisms and systems that really enable us to track things of this nature? So monkeypox virus, as you know, it's a very different kind of virus. Actually, earlier this morning, I received an extraordinary phone call from one of the contributing editors in chief for the Infectious Disease Society of America journal. I think the goal is to write a systematic review around some of the monkeypox outbreaks that have occurred in the past, and so we can trace a trajectory for the future and things like that. But it's important to recognize that monkeypox is a DNA double-stranded virus. It's different from SARS-CoV-2, which is primarily an RNA virus. So what that really means is DNA viruses tend to have a polymerase chain enzyme, or an enzyme that helps to autocorrect replication errors. So there's not a lot of mutations that you would likely experience with that specific virus. So
Looks like we lost Bryan. Yes,
yeah.
Looks like we lost Bryan.
Yeah, I thought it was from my end.
Okay, Bryan is back.
Okay.
Yeah, I'm sorry. I have no idea what happened.
Yeah, we lost you for a few seconds, but please just take it away. You can go on.
Oh, okay, yeah. So when you have a virus or a disease that has very high mutation rates, for instance, there's a lot of genetic diversity that might occur that makes it possible for many applied genomic epidemiology applications. So for the case of monkeypox, it's not really the case, because the mutation rate is still very, very low. If you look at the whole genome sequence for the monkeypox that emerged in West Africa in 2018, and you look at and compare that genome with what we have that's circulating in Europe right now, in Portugal, in the UK, they are very, very similar. There's not a lot of genetic diversity in terms of single nucleotide polymorphisms and variations and things like that. But I think it's really crucial and very important for us to build these kinds of surveillance mechanisms in general that would really help us to pick up these kinds of signals. So I think this discussion is very important. I just wanted to make my presentation or my remarks very brief so that we can maybe dedicate more and more time to discussions and maybe explore ways in which we can be better prepared. I just want to share some of my experiences, my working experience working in the United States with the CDC, working with the State Health Department, and also my work with the Africa CDC. And I'm really happy to see that in the audience I'm seeing multiple people from the Africa CDC who are represented. So that's really great. And I hope we can really have a very healthy discussion. So one of the things I think we've probably have come to recognize is the threat, the global health threat, why we are beginning to see a lot of zoonotic disease emergence and why this is kind of happening. So this is just an overall global health map that shows some of the hotspots where we see really an estimated risk of zoonotic disease emergence. And there are many reasons to think why this might be happening and why this is continuing to happen. It's really an increase in urbanizations and just a plethora of factors that result into this shift in the dynamics of infectious disease, emerging infectious diseases in general, and health threats. And the conceptual model that we frequently hear about is this human animal interface, so the One Health approach, because as we as humans, as we interact more with wildlife, we tend to share microbiome or share the organisms that naturally habitate within us as humans tend to cross over or may spill over to other species, and organisms that may habitate in animals more at ease might be able to cause diseases in other organisms. So when we think about this really One Health approach, this interface between humans and animals and the environment and all the other social factors that come into play, it's really very important for us to think about the different factors that interplay with this. So from a demographic point of view, we are seeing an increase in population landscape. We're seeing a lot of population increase globally. We are also seeing an aging population. We're seeing more and more urbanization happening, and increase in transportation and mobility and things of that nature, and other factors as well from a social standpoint, governance and policies and institutions. And so these are things that are really having a great change or having an influence in how social changes that are actually having an impact on global health. And also we have economic factors that we also have to think about, like trade and capital mobility and labor conditions and wealth creation. So a lot of things have been happening in the last few years that I think has been accelerating and increasing that's affecting the equilibrium between humans and how we interact with the environment and the ecosystem and climate change and things of that nature. So I think this is these are some of the things that might be accelerating some of the things that we are seeing. We are hearing more and more about disease emergence. We are hearing more about zoonotic spillover events. We are hearing more about that. But the question is, do we have the kinds of surveillance mechanisms, and do we have the kinds of surveillance systems to really help us to tackle those, or to identify those early? Here's a slide that I borrowed from one of my colleagues about I think the Ebola outbreak that occurred in Central in the DRC a few years back, that really shows some of that interactions, that some of those changes that we see around the human-animal interface, and the importance of thinking about these different approaches. There are 7 main anthropogenic drivers for zoonotic diseases that I wanted us to think about this. The first thing is, there's been an increase in the demand for animal protein, so increase in the consumption of animal source food. So there's been an increase in agricultural intensification. So that sort of bridges the ecosystem for animals themselves. So that's definitely affected that equilibrium as well. There's been an increased use and exploitation of wildlife. And like I mentioned before, and as we are interacting and encroaching on the human habitat, or the habitat of animals, there's organisms that naturally habitate within animals would tend to live with us. So there's been also unsustainable utilization of natural resources that has been accelerated by urbanizations and land use, and increase in travel, increase in transportation, changes in food supply. And I cannot overestimate the role of climate change and how global warming and influences of that nature are equally affecting our ecosystem. So these are some of the things. I think we cannot really talk about pandemic preparedness without really talking about One Health and talking about all these different dynamics and the environment and the importance of climate change, and all these other factors, and how all of these are related to our health as individuals. Now, I wanted to shift gears a little bit and talk a little bit about epidemiology and the role of epidemiology in pandemic preparedness. So just a brief one sentence, the way I like to think about epidemiology is really all about finding the right numerator and finding the right denominator. That's what epidemiology is all about. And applied epidemiology, and when we think about epidemiology, there are really 2 aspects to epidemiology. There's the academic part of epidemiology, and there's the applied part of epidemiology. And the applied part of epidemiology is really implementing changes that would affect the numerator and the denominator, and how do we communicate those to the public. I think we've all learned through the COVID-19 pandemic how important it is, how important communication is. I think we've come to increasingly recognize the role that sociologists play and anthropologists, and how this communication, how crucial communication can be when we have research findings, and how those findings are actually being communicated to the public, whether it's about vaccine efficacies and things of that nature. So many lessons that I think that we probably should have learned throughout the pandemic. And there are different aspects to how involved we are with the public health response. This is a health pyramid, about folks here might be, if you've done public health training, you may have come across the health impact pyramids, the different factors that affect our health, from the socioeconomic factors from a larger scale, and narrow that upwards towards individual one-on-one patient interaction and patient care. But taking COVID-19 as one example, I just wanted to highlight the different roles that we do play in the the COVID-19 response. This is a slide that I presented several months ago at the Nebraska Public Health Conference, and we're talking really about the different interventions that we do play, because as individuals we have different roles. We sometimes as epidemiologists we generate the data, but the data has to be useful, has to also inform policy. So we have to work hand in hand with stakeholders as well, and legislatives and governors and all that, to come up with the directed health measures or DHMs that really impact the communities that we do serve. So for a disease like COVID-19, there are multiple interventions that were available throughout the pandemic. So things like distancing and masking and testing. So we all have different responsibilities. So as individuals, your responsibility, for example, throughout the COVID-19 pandemic could have been distancing, for masking, for instance, and testing whenever you feeling unwell. Then the role for case investigators or epidemiologists and individual and contact tracers and things like that could be to really just generate the data, doing the case investigation and contact tracing, calling individuals whenever they are sick and letting them know that they needed to quarantine. But in order to do that, you need to have a sense of, what the disease is. For a disease like monkeypox, it's still not very clear what the, what the dynamics of the disease is. We think the incubation period is about 21 days. So that's approximately how long an individual might be requested to isolate or to quarantine. To isolate if they are ill, or to quarantine if they've been exposed and things like that. So having a sense of that and being able to gather that information early and in real time and communicating those findings to the public is really crucial. So I just wanted, on this slide, to highlight the different groups that are responsible for different interventions. The distancing and masking, again, these are our individual responses. This is what we have to do as individuals. Case investigation and contact tracing is what we do as epidemiologists. We do call people when we hear that there is a disease outbreak and things like that. We call people. And I think one of the things I learned throughout the pandemic, because I have investigated multiple outbreaks, I can count how many. I led the investigation of the very first Omicron variant cluster that was identified in the United States, and have been involved in multiple outbreak investigations throughout the United States. And I think it's been a really great honor and privilege to do that. I learned a lot by calling, speaking to people over the phone, and even how you talk to people over the phone, and how you, getting information from them about their symptoms and trying to understand. I remember early on when we had the Omicron variant cluster, and we wanted to understand if the clinical characteristics of Omicron was distinctively different from what we had with the Delta, and that was the case, because we're not seeing a lot of people with anosmia, right, and loss of taste and loss of smell, and why those were distinctively different with those groups and not other groups. So doing our due diligence and doing what our role is, generating the data and sharing that data, and coming up with directed health measures to guide the population on what needs or might not need to be done. And we would typically come up with, again, this was early on in the pandemic. We used to generate these kinds of outbreak maps where we show the blue lines here indicate primary cases. So where we show how individual transmission actually takes place from a specific outbreak setting to people within the community, and building these kinds of transmission networks and establishing a line list and documenting all of that. that and being able to understand how different disease, how transmission is occurring within a specific outline or a specific group, and outlining those clearly. But today we have very beautiful tools like R and Python that really enables us to develop some of these tools in real time and develop line lists and epidemiologic curves like what you're seeing on this slide, and establishing different visualizations to see or to understand how what the incubation period for a disease might be, and what quarantine measures might be needed at what different interventions or different points in time. So all of this is really important from an epidemiologic point of view to really understand what the disease you're dealing with and what the transmission dynamics or the characteristics of that specific infectious disease is. I also wanted to talk about some of my work with the Africa CDC. When the COVID-19 pandemic started, I foresaw that variance was going to be a concern or was going to be a problem, and have been involved with the Africa CDC. And initially, the goal was to help.
We lost your voice, Bryan.
Still not getting. Maybe you unmute again? Yes. No.
Yeah, so again, sorry for that. I'll try to use my computer audio, if that's okay. Can you hear me?
Yeah, we can hear you perfectly.
Awesome. Again, I really apologize for that. I have no.
It was very interesting. Please just keep going.
I have no idea what's happening. So early on in the pandemic, I had very long discussions with the with colleagues at the Africa CDC on the importance of just setting up a genomic surveillance system that works. So what we've been doing is really collecting genomic sequences from, all, and it's been a huge collaborative effort between member states and getting all genomic sequences from all individual member states and trying to look for genetic signals and genetic fingerprints within those signals, within those individual sequences. So we do have a system that can really enable us to identify new variants before they become problematic, and we're able to use different kinds of epidemiological models to predict what lineages or what specific variants might emerge and become problematic. So we launched this tool called it's a next-strain build, which myself and Gerard Bua at the Africa CDC Pathogen Genomics Initiative have been maintaining, and we've been maintaining this for a long time now. And basically, and we've tried to automate this process now, so we are able to pull genomic sequences from weekly from all the public health laboratories in across the continent, and we are looking for specific markers or specific mutations or specific genetic changes that we think might have implications for public health, could lead to maybe a new variant of concerns and things of that nature. So we've really been on the front line on this, and I'm really fortunate to have an amazing group of people that I work with. So it's really been really amazing, and we've been building phylogenetic trees and tracking and looking at viral evolution. But one of the things I really wanted to highlight on this slide is how the turnaround time for sequencing has really been decreasing. Early on in the pandemic, the turnaround time between when a sample was collected and when it's eventually sequenced and submitted to GISAID was so long, but that time has really decreased over time, and we are seeing much shorter turnaround times and more utility for even the genomic data. So that's made things even a lot better. So I am very, very, very proud of this, and I'm hopeful that
in the next coming weeks, we will be able to establish a similar mechanism or a similar kind of system for Cameroon as well. And I've had some discussions with some of the members of Epicenter in Cameroon as well. We're doing really incredible work. I see that Dr. Yap is in the chat as well. So maybe we have some on how we can establish similar kinds of systems and mechanisms for Africa. I wanted to talk a little bit about, again, there's this, I want to talk briefly about the monkeypox outbreak, sorry. I want to talk a little briefly about the monkeypox outbreak that I think has been on the news for the last couple of days because it's kind of a little bit problematic and stuff. But monkeypox is a little bit very different from SARS-CoV-2 in the sense we still don't really have a very good understanding of what the role of asymptomatic transmission is. We do not know if people who do not have the vesicular rash or the vesicle and the pustules, whether or not in the absence of those clinical symptoms, they are able to transmit. So the role of asymptomatic transmission, what that might be playing in onward disease transmission. And I did have a discussion with Dr. Mono Kenne yesterday, and we're having a discussion about this. And he did give me some insights and advice on, you know, maybe we should really have very well detailed line list characteristics of the 142 monkeypox cases that we do have, both the confirmed and the suspected cases, and try to establish what their clinical profile is and what their characteristics are, and how we can hopefully determine if the clinical characteristics of this specific monkeypox outbreak is different from the other one. But what we were able to quickly do was to look at that very unique, because in the United States, we just had the first monkeypox complete genome sequence submitted to the NCBI yesterday. So build a phylogenetic tree on that just to look at how related those are to what we have before. So what you're seeing on the left, these are the sequences from 2018. So very, very distant, genetically distant. Like I mentioned earlier, this is a DNA virus. So we will not see a lot of genetic diversity and single nucleotide polymorphisms to explore a lot of for many genomic epidemiology applications. So it's a little bit different and a different kind of niche and stuff like that, but we can use genomics to make some inferences. But I really want to caution that when you look at the phylogenetic tree, it's very important to recognize that we cannot infer directionality from a tree alone. The epidemiological context that relates those individual cases on a phylogenetic tree is very crucial when making any kinds of inferences about disease transmission. So you cannot look at two sequences and say, this individual infected this person. That's not really what genomic epidemiology is for. It really shows us what the epidemiologic dynamics is, but it can really, you can use genomics data to confirm that this individual transmitted the infection to this person. But you can absolutely look at two sequences and say this person and this person are unrelated genetically, they are unrelated and things like that. And that's how useful that data is. So I've been on top of this. I've actually spent the whole of today working on this and trying to build this phylogenetic tree. And we are working on building a review on some of the cases that outbreak cases that we've had in the past, and how we are going to delineate those and better understand what's happening and how we can better respond in the future. So and the reason why I think it's important for us to talk about monkeypox is because we just coming out of a pandemic. So there were so many lessons to have learned throughout the COVID-19 pandemic. Just how important it is for us to set up disease surveillance mechanisms and disease surveillance systems. And I think we've come to recognize the importance of data science and the tools of data science and things like R and Python and SAS and Stata and all the different tools that people can use and could use for public health surveillance and things of that nature. Those have become increasingly important. And I think we've also come to recognize how crucial and what an important role epidemiologists and anthropologists and sociologists and what an important role they do play in the public health landscape. So essentially those are the few things that I really wanted to share with the folks today. I would really like to pass on the mic to my friend and colleague, Dr. Karl, who I have a lot of respect for. He's been very useful, very important in the COVID-19 response efforts in Cameroon, and I really wanted him to share some of his experiences working in Cameroon and how he's been involved with some of the COVID-19 response effort. I know he was involved with the organization, with the planning and the public health control measures during the African Cup of Nations as well. So I'm really, really excited to hear about that. And coming from Cameroon and having experienced what the medical system is in Cameroon and experiencing what public health is in the United States and experiencing what it is at the state level or at the health agency, or the large health agency, has given me really very different perspectives and different ways of appreciating how public health could be better optimized and could be used to improve global health. So Dr. Mono, thanks a lot for really giving me the chance to talk about some of these issues that I'm really, really passionate about. And I'm really looking forward to an exciting discussion. I also see that Dr. Kenji is on the call, so I really would love to gauge his interest about the role of laboratory, clinical laboratory diagnostics as well in pandemic preparedness and all that. So thanks a lot, everyone. Thanks, appreciate it.
Thank you, Bryan. Thanks for this exciting beginning. I'm not sure, can you hear me?
Yes, we get you, Alison.
Okay, awesome. Thanks. So thanks for this exciting intro. I'm feeling like it's going to be a great day. And we've shared the links to some of the Dr. Tegomoh's publications in the chat around genomic surveillance. So please feel free to read these publications and maybe think about potential areas of collaborations or contributions to the work that he is doing together with the Africa CDC. And before we hand the floor to our next speaker, Dr. Karl, I think I'm just going to check on how people are feeling in the house. And there is someone in the house that I couldn't just resist poking, and that's Dr. Yap Boom. Hi, Prof. Dr. Yap Boom, vous êtes là?
Yes, good evening and good morning for you. I'm really happy and a bit excited to hear all what has been said so far. I look forward to what Karl is going to present and also for the discussion session. Thank you.
Thank you very much, Dr. Yabum. So Dr. Yabum is at the Epicenter, and he is a teacher and mentor to many of us, and he's a senior epidemiologist and researcher, and we're excited to have him here in the house with us. So maybe for the interest of time and to make sure we have enough allowance for questions and answers, because I see them coming in already in the chat, I'm going to hand over to Dr. Karl to take it over.
Thank you, Alison. And thank you, Bryan, for setting the scene for me. And sometimes it's quite difficult talking after you. Okay, but I was contacted by Bryan to actually talk about pandemic preparedness and lessons that we learned from the SARS-CoV-2 pandemic in Cameroon. So I proposed to him we should talk about the lessons we at Epicenter we learned and what Africa is learning from the different SARS-CoV-2 seroprevalence and mortality surveys we did across Africa. And I'll be presenting our work in Côte d'Ivoire, in Cameroon, in DRC, Kenya, Mali, Niger, and and in Sudan. So, yeah, obviously, Professor Yabum is present on the Zoom meeting. I would say Professor Yabum is the regional representative of Epicenter to Africa, and as Alison Riley said, he's a teacher and mentor, and he has been quite involved in much of this work, and I'm sure most of the questions he's going to help me answer them. So Cameroon actually did a lot for the SARS-CoV-2 pandemic. We are one of the first countries, especially in Africa, to actually have a public health emergency operations center up and running. And this to perform the field epidemiology that was involved in contact tracing, in isolating, and also in the management of the cases of COVID-19 in Cameroon. So it was quite important for us to evaluate the real consequences of the pandemic in the different contexts in Africa, and to estimate the rate of infection. And so we decided to implement different seroprevalence surveys of antibodies against SARS-CoV-2 virus. And since we know the general population surveys are resource intensive, we first wanted to assess the relevance of conducting blood donor surveys to estimate the situation and monitor the trends. And this was what was done in Kenya, in Mali, sorry, and then we now went further to do population-based surveys in Lubumbashi, in Abidjan, and then in Cameroon. So at the beginning of the pandemic, what did we do in Cameroon? We actually started by evaluating the performance of rapid diagnostic tests for the detection of COVID-19. We know doing PCR tests is quite expensive and sometimes unavailable in the low and middle income countries like us in Cameroon. So we actually decided to design this study, which was to actually measure the performance and operational feasibility of the antigen and antibody rapid diagnostic test for COVID-19 in both symptomatic and asymptomatic patients. And this showed a quite great performance for this test. And we can see here, our main interest here will be with the antibodies. And we see the antibodies, the sensitivity for the antibodies test was averagely high, it was 59%, but in the symptomatic people. And we saw that above 14 days, we could detect more and more people with antibodies. So in late 2020 and early 2021, we actually assessed the duration of SARS-CoV-2 antibodies in the blood of Cameroonians, and we published this on Scientific African. And as you can see from the figure, we have the positivity of the antibodies from natural immunity actually decreased over time, especially for the IgG and the IgM, and they decreased above 20 days. They started becoming undetectable in the bloodstream. So what do we learn from the seroprevalence surveys we did? Before we want to talk about what we learned, we need to talk about why did we do this seroprevalence surveys. And the first thing was to assess the rate of infection. And as I mentioned, we did that for blood donors in Mali, and this helped us to follow the different trends that could be similar to those in the general population. And after this, we also performed these same seroprevalence surveys amongst health staff in Niger, and then amongst the general population. And also we wanted to assess the level of herd immunity and the influence that different response strategies like confinement, isolation, and the vaccination had to play in the immunity of the population. So the first survey we did was in Mali, which is still ongoing. And this included blood donors from the MSF project in the Koutiala region. And as you can see from the RDT, we had a total of 23.7% of people who had a positive antibody test. And when we did the immunofluorescence test, we could see up to 65.3% out of 104 people that were tested. So the results from Mali show a high seroprevalence rate based on lab-based diagnostic tests for seroprevalence. And if we look at the general population, the proportion of infections was much higher than the number of cases reported by the surveillance system in Mali. And the analysis of seroprevalence over time in Mali does not show a clear trend and does not reflect the trend of cases at the national level. We then did the survey in Maradi region in Niger, where we actually surveyed the health staff. And we look at this table, we have the number of cases that have been declared in Niger. We see in Niger, since from the start of the pandemic, had a very low number of cases, a very low number of cases. But surprisingly, when we did the seroprevalence survey amongst the health staff, we had 42.3% on RDT, and from laboratory testing, we had 84.5%. Yes, and from PCR, we had just 7.6% of PCR reported cases amongst health staff in the country at that time. It's true, we could say this high prevalence could be explained by the fact that these people are health personnel, but at the same time, given the low positivity on PCR and also the low rate of infections in the country at that time, it's quite plausible to understand why this high rate of seroprevalence of SARS-CoV-2 antibodies. So these pictures here show how most of the studies were carried out. It's like the population-based studies, where we moved from door to door and we surveyed large populations, like in the case of Cameroon, all over the 10 regions. We actually did in the main capital cities. And we collected blood samples, not just for the RDT, but also for laboratory-based testing. So the next survey was in Sudan, in the Dagale camp, and yeah, I won't talk that much. The seroprevalence in this camp was at 5.8%, and this population survey in Dagale is offered a pleasant surprise in the estimated seroprevalence by RDT, which was quite low, and the isolation of this refugee camp of over 80,000 people and the strict screening of arrivals may have produced this effect. So such prevalence suggests that about 5,000 people were infected, while only 78 cases have been reported to date. And 81% of seropositive persons reported having at least one symptom associated with COVID, with a median of 6 symptoms, compared to 45% of seronegative persons with a median of 3 symptoms. And these symptoms lasted for more than a week for 52% of the seropositive persons, compared to 30% of the seronegative persons. And this survey included the general population recruited from health posts and all community workers and their families. There's a second cohort that shows a significantly high seroprevalence, which is 2 times that from the first study. And then we moved to Abidjan in Côte d'Ivoire, where we did a household survey amongst 1,861 participants. And the overall seroprevalence here was 35.6 on RDT, and on ELISA we had up to 79.4%. And amongst these who had a positive seroprevalence result, 19.0% had taken vaccines before, as low as 19%. And then we have the survey from Sudan. Yeah, it's mainly was in the greater Duran area in Sudan, and we see the seroprevalence of 34.3% in the general population on RDT. And when we adjust the results with the sensitivity of the rapid diagnostic test used from the manufacturer, we could go up to 54.6%. So in Lubumbashi in the DRC, we did a study which was conducted in 2 health zones in Lubumbashi, that is the Lubumbashi health zone and the Kampemba health zone. And the study setting was difficult with a high proportion of refusals related to the rumors about COVID-19 vaccination. More than 50% of households refused to participate, and nearly 50% of individuals in the consenting, and nearly 50% of individuals in consenting households refused to participate. And that brings us to the question of communication during a pandemic like that of SARS-CoV-2, where sometimes the communication is not that clear, it's not inclusive, doesn't involve the community so much such that every intervention is seen as negative. And then sorry, is somebody talking? Okay, I will continue. So we were able to recruit up to 2,040 participants from 633 households for the serological survey, with a median age of 20 years, and 45% of them were male. So the preliminary results show that of these, 321 individuals tested positive using RDT, and giving an age standardized seroprevalence of 15.7%. So data cleaning is still ongoing, and we hope to report more of these results in future communications. And then we come to Cameroon. In Cameroon, we had the emergency declaration of COVID-19 in Cameroon sometime in March 2000, in May 2020, and from then we have had different waves of COVID-19, and we had the arrival of vaccines, the first vaccines in Cameroon, mid 2021, and then we had the study which occurred, which was between July to August 30th, 2021. So this is one of the largest seroprevalence, population-based seroprevalence surveys in Africa, with almost 5,739 participants included from 3,992 households, and the median age was 24 years, and 45% were male participants, similar to other African countries. And the overall seroprevalence here with RDT was 18.3%, and with ELISA was 20.5%. So here is just a summary of seroprevalence according to the rapid serologic test in Cameroon. And we see that there's a significant difference in the seroprevalence in the greater or equal to 50 age group, where we will have a higher seroprevalence than the others in the other age group. This could be explained by the fact that more and more as time with progression to the pandemic, we had more and more of people above 40, 50 who accepted to take the vaccine, given the communication around the risk factors for COVID-19 severe disease. So amongst the vaccinated people in this survey, we had 83% of them had a positive antibody test. And here we can see from the vaccines available in Cameroon, and some people actually had some other vaccines out of Cameroon before coming in. We had AstraZeneca, we had Johnson & Johnson, we had Pfizer, Sinovac, and most of the population took Johnson & Johnson. Most of the population during this survey took Johnson & Johnson, maybe because it was just a one-shot vaccine, and they welcomed that idea better than having a two-shot or an mRNA-based vaccine. So we can see that the COVID-19 seroprevalence in Africa is quite dynamic, with numbers as high as 84% and 79% in Abidjan and Niger, but we have a seroprevalence of 18.3 and 20.5%, which is which makes us question ourselves, especially in Cameroon, if we have this seroprevalence as low as 20, as low as 18.3%, are we really at the level of herd immunity, as many people are trying to explain our low transmission or the low number of deaths in Cameroon, with the fact that we may have had a lot of people infected before and they had developed some sort of immunity against SARS-CoV-2. And so this requires further investigations. And but beyond the seroprevalence, what more do we need to do? So we decided to do retrospective mortality surveys to explain the possible low death rate in Africa or in these African populations. So for Lumumbashi, we recruited over 3,500 households, and we observed 153 deaths amongst the 19,733 household members during the recall period from January 2020 to May 2021. So the preliminary analysis showed that the estimated crude mortality rate was 0.1 per 10,000 persons per day during the baseline period, and was significantly higher at 0.28 during the second wave from November 2020 to May 2021. So, but this increase is also observed in several age groups, including the less than 20 years, suggesting that the increase in mortality may not be directly related to COVID-19, and additional analysis are on the way. So this is similar to what was observed in Abidjan, but however, we see if we look at the mortality in all the population, especially in the 50 years and older, where we expect a higher mortality, we discovered that in pre-pandemic periods, we had a mortality rate of 0.27 compared to pandemic mortality rates of 0.28, which shows no real difference. And we moved to Cameroon, where in Cameroon, we had 6,155 households recruited for this study. That is a total of 22,314 people during the recall period. And we discovered 238 deaths in this population from January 2020 to August 2021. And this is the results from Cameroon are, however, similar, but somehow different from that of from that observed in Abidjan and Mumbashi, where we have in the 50+ age group. Even though this result was not statistically significant, we had an increase of 0.26 per 10,000 to 0.76 per 10,000 during the pandemic period in mortality in the 50 and older age group. So seroprevalence and vaccination, what is the link? And as Dr. Foma rightly put before, the vaccine coverage in Cameroon is however poor if compared to other countries, with just about over 1.8 million people have been vaccinated so far. So we decided to do a nationwide vaccine acceptance survey, and generally we have a low acceptance of vaccines in Cameroon, of COVID-19 vaccines in Cameroon, but it was surprising to see that the Adamawa, the extreme north and north regions actually had a high acceptance rate for COVID-19 vaccination. So could this be could this be because of differences in communication strategies in these northern regions compared to the southern regions? Or could it be the level of education, which we saw here that those with no education and with lower level of education had a higher rate of vaccine acceptance? And we could maybe blame some of these reluctance to accept COVID-19 vaccinations to access to social media and anti-vax discourse. So we interviewed a total of 6,343 people with a global acceptance of 37%. How do we improve such numbers in Cameroon? So it's by understanding the reasons why these people don't want to get vaccinated, and doing more research to show to them that these factors are not actually true. So when we ask the people who did not want to get the vaccine, why don't you want to get vaccinated? The main reason that came was the vaccine is dangerous. And this was in about 30.3% of the surveyed population. And this comes about due to maybe the communication surrounding or around the pandemic, the communication around this vaccine, but also due to a lot of anti-vax campaign that is ongoing. And if in African nations, or in Cameroon in particular, we could do more surveys to show the safety, as Dr. Foma put in his introductory slides. We have vaccinated billions of people. That's greater than any other vaccine has ever achieved. And we know what the side effects are. And if we can communicate adequately to these populations on such numbers, then it could help in improving the vaccine acceptance rates. So what these surveys teach us, we discovered we had a high seroprevalence, which was not expected looking at the number of cases reported by our surveillance systems. And the results suggest an impact on mortality, especially amongst at-risk population, that is those above 50 years. And there's a necessity to vaccinate the older population and other populations at risk, and to also intensify the communication to promote vaccine use and vaccine efficacy studies to promote acceptance. And also we have to plan frequent seroprevalence surveys to adjust COVID-19 response, including vaccination and the emergence of new SARS-CoV-2 variants. Here is the evolution of COVID-19 in Cameroon, where we had the first wave that occurred for almost 16 weeks. And here we had, was from the 27th of April of 2020 to 16th of August 2020. And then the most lethal wave was the third wave with 2% case fatality rate, and with more than 38.8% of those infected on oxygen. And it was from the second wave that Cameroon started doing genomics surveillance, even though, yes, these platforms have not yet been well developed back here in the country, but some of these samples were sent and sequenced in other African nations like Nigeria. So we had the Alpha, Beta, and then we had the Alpha and Beta, but the Delta variant accounted for most of the cases in the most severe third wave of the pandemic. But we had the fourth wave, which we had many of the cases were due to Omicron, and that was one of the most, the least severe waves we had in Cameroon. Ever since then, it's been weeks now, Cameroon has not notified any new cases of COVID-19. Is it, do we have to intensify surveillance, which is already so well done, or is it that COVID-19 is away from Cameroon for now? Well, anyways, we will watch and see. So the conclusion from these slides is no one size fits all. And we need to learn from this pandemic in order to apply this to future pandemics that may occur. We need to understand that every context has its own peculiarities, and we should tailor the needs, we should tailor the approaches or the interventions according to those needs. And as this comment on the Lancet says, no one size fits all approach will succeed within a continent as diverse as Africa, where local solutions should ensure COVID-19 is not only a challenge that is met, but also an opportunity to strengthen the health systems before the next pandemic. Thank you.
Thank you, Dr. Fai. This was really interesting and exciting. I'm telling you, I was just watching the comments in the chat and some of the reactions, and I know that it's going to be quite an engaging Q&A session. So what I would recommend is just have a quick leg stretch and grab a cup of tea, and then let's dive right into the Q&A. And I know there are a few questions regarding what you and Bryan have presented, but I would like to begin this Q&A session by showing a little bit of publicly available data, because I know it's going to shock us all sitting here, and I'm hoping that this is going to be a forum for reflection and brainstorming about the roles of each and every one of us that's sitting in this town hall today. So we can see that the folks at the Epicenter, as well as Bryan and his team at the Africa CDC, are already doing a lot of work we would see this data and we think, oh, well, this is just a publication. But the amount of research and thought and work that goes into this work is phenomenal. The amount of collaboration and brainstorming that goes into this work is phenomenal. And we have to ask ourselves that as scientists, how are we contributing in our own little ways for the capacity development with regards to pandemic preparedness in our countries? And I'm going to share, like I said, publicly available data, which I'm hoping that would shock us enough to get everybody into thinking mode and pondering mode about what they are doing. So there's this thing called, so the international health regulations have what you call, just a minute, there you go. They have this document which is published, and I'm going to share the link in the chat. And it's called a joint evaluation, it's like a joint external evaluation tool. And how did all of this come about? So BREF decided that, listen, countries need to be prepared for pandemics. We don't have to wait until the pandemics come and then we are scrambling to see what we can do. If we are prepared for pandemics, then it makes us ready to handle these pandemics when eventually they come. And how do they recommend that countries be prepared? Countries need to be able to prevent these pandemics, and these are the different aspects of prevention that are expected to be available in each country. So you have national legislation, coordination, monitoring, and prevention of antimicrobial resistance, all of these aspects under prevention. Countries need to be able to detect these pandemics or outbreaks, whether it's epidemics or pandemics, in a timely way to enable a response. And detection would involve having adequate national laboratory systems, surveillance, reporting, and human resources. And we can now see where Bryan's Africa CDC kind of fits in, because they've been doing a lot of surveillance. Countries need to be able to respond to these outbreaks when they occur. So we need to be ready to respond. And we need to have international health regulation related hazards and points of entry monitoring. So monitoring for chemical events, radiation emergencies, and all of that. So these are publicly available publications, which we could always share, and the moderators would share some of the links in the chat. And they have several ways of monitoring progress. So the joint evaluation, usually you would have like experts who come into a country and work with the country Ministry of Health people to assess how ready the country is, so as to better support that country with regards to the gaps that we have. Then you have this other tool, which is usually updated by the WHO. It's called the State Party Self-Assessment Annual Reporting Tool. So countries actually assess themselves to see how prepared they are, and they, based on guidance and documents that are provided by the WHO, and they provide this data to the WHO, and the data is updated on the website. And this is how Cameroon ranks. So for those of us here who are not Cameroonians, I know this might be a bit of a detour, but since the audience is primarily Cameroonian, we'll look at Cameroon, and you might be interested to look at how other countries are performing. But this is how Cameroon ranks. So there are, let me see, I'm just gonna minimize this. So there are about 15 different capacity indicators that are being monitored. So in terms of policy, we rank, so the top upper line shows the global average. The next one at the bottom shows the regional average. And this is data for Cameroon for 2021. And with regards to the availability of policy and legal normative instruments, we rank well below both regional and global average. So most of our indicators, we are not performing too well. There are some indicators, for example, however, such as coordination, laboratory capacity, and monitoring of and prevention of zoonotic diseases, where we are making a lot of effort. But we see things like infection prevention and control, food safety, availability of proper policy and legal and normative instruments. We are really, really lagging. So it's okay for us to come here today and sit and listen to people who are working hard to boost some of these capacities, whether it's at the level of laboratory or even disease surveillance, as we've seen with genomics. But each of us has a role because we find ourselves working across the different sectors. Many of us here would fall, for example, maybe under human resources. It's true that we tend to say the biggest role lies on the government to ensure that there's capacity, but we've been trained to be able to do some of these things. What are we doing individually at our various job sites, whether it's at managerial level or public health, prevention level, or public health practice level, or even clinical practice? What are we doing at our various levels individually to ensure that our country is faring better in terms of pandemic preparedness and responsiveness? So I just thought I would begin this Q&A session by, calling on each person to just reflect and to think about what your role is, because we've seen amazing data coming from Epicenter, amazing data coming from partnerships with the CDC Africa. And we can sit here and just listen to all these people doing the work, but we should keep in mind that we each have a role to play. Okay, so this is data that's available, and I'm just going to share some of these links in the chat, and I'm going to stop sharing my screen so we can dive right into the Q&A session. Dr. Muno, I see you're unmuted.
Yeah, Alison, I'm unmuted, but okay, you want me to start with the first Q&A? Yes. I was very impressed with what the Epicenter is doing. Like, I was really impressed, and I feel they too have a problem with communication, because this is data we have to know about. Because really getting data is true. As scientists, we love to publish in big journals, but we have had this problem with COVID. That's not how information moves around during a pandemic. We need to know exactly every scientific publications. We need to get a good PR to pass across this information. So I'm truly very impressed with what they're doing and the data they have in Africa. I've been trying to fish out some. What is amazing to me is really the discrepancies that we have between the level of prevalence, the prevalence of seropositivity among different African countries. Mm-hmm. I'm amazed with that. And also I want to know from either Prof. Who is here, and also from Karl, if there could be an explanation why we do have a difference between the RDTs and the ELISA in other countries, like what I saw in Senegal, what I saw in Ivory Coast, the prevalence, the RDCs and the ELISA, there was a huge gap. But in Cameroon, which kind of, I actually believe the data in Cameroon more. To me, based on what I'm seeing in the pandemic, the reflection of the 18.3% of prevalence and also the 20.5% that you see in the ELISA they are very close together. So I want to understand if they, in their analysis, could figure out why we had this huge difference. And most African countries do not have a very high vaccination rate. But I just wanted to know if they could understand these differences between the ELISA and the RDCs, which with the PCR is understandable that actually if you don't have virus, your PCR is not going to be positive. But I wanted to know between the RDCs and the ELISA. And I also wanted to know the difference in prevalence between one African country to the other, especially those who are just in West and Central Africa, close together, similar population dynamics. Most of them have a median population age of about 18 years. I'm not going to expect most of them to develop COVID and severe COVID, and this makes me to really start thinking that we need to really up our game, use this data to actually get Cameroonians vaccinated, that our prevalence of this, our prevalence is not very high. So we still need to get this vaccine in. So I just have that little for Professor Yap and also for Dr. Karl, if they could give us an insight and if they do understand what was happening in this data. But I want to applaud them I'm very amazed with what they're doing back home in Cameroon and in Africa overall, and I applaud them. And I think Africa has a lot to teach the world in this pandemic. And I also feel like what we saw in South Africa has been in the leading front of identifying variants, meaning they just got stigmatized for having a very good surveillance system and picking up variants ahead of others, even first world countries. I mean, New York City, I can tell you, I can spend a whole day criticizing maybe what some of the agencies are doing, which I don't feel they are doing a wonderful job in themselves. But so truly we have had more pandemics in Africa. We have had a lot of tropical neglected diseases that we're dealing with, not only Ebola, but several other ones. And our local epidemiologists and those who are working in the field may have more experience in actually picking up these things and dealing with them better. So I just want to applaud them first. One is just a comment, and then you have the two questions we have there. Thank you very much.
Thank you, Dr. Foma. Professor Yap or Dr. Karl, would you want to respond to Dr. Foma's comments?
Okay, I will take the floor. I think Professor Yap got me there. Okay, yeah. So yes, it was quite interesting to see these differences, especially for the other African countries where we have maybe seroprevalences at with RDT at 30, 34, then we have as high as 80 when they do the fluorescence studies in the laboratory. So we haven't yet come up with quite a great explanation for that, because we are still investigating this data to see how the samples were collected, how they were stored and transported in these countries, and also if there's a difference in using the different ELISA platforms or the different immunofluorescence platforms that are available. You can say like in Abidjan, they use the Roche. Here we use the bioMérieux platform, which actually detected the IgG2. And here in Cameroon, we actually collected dry blood spots on filter paper from the different study sites, which we transported to Yaoundé, and then they were extracted, and then we run and then from there we could run the serological test. So at one point we were thinking, okay, maybe we are the ones who maybe did the poor collection, maybe in terms of dry blood filters, dry blood spot filters. Maybe these are not like optimal for measuring SARS-CoV-2 antibodies. But at the same time, these results from Cameroon are plausible and are quite realistic, as they give us an image of what is happening on the ground. And then we could also talk about the RDTs, the kind of RDTs that were used in the different countries, maybe talking about their sensitivity and especially their sensitivity. I can see Dr. Kenji is raising his hand, and we can learn a lot from him here. Yeah.
And so I was trying to say the question is also for Kenji, because question 2 was, thank you, Dr. Karl, for that explanation. And I also thought I really wanted to talk about the different platforms, and you brought that up. I thought all the studies used the same platform for ELISA that was used. I want to add to that for Kenji to try to answer my question. Do you think there was also cross-reaction occurring with different SARS infections that may have happened in Africa with the different ELISAs picking up, depending on the proteins that were put in the ELISA pack? I just want to know exactly what your thought process is. You're working in—
Yes, you are on track, Dr. Foma. What we are seeing is that there's a lot of cross-reactivity, especially with the N protein. So it depends on which protein was used in the RDT, which protein was used in the ELISA. Initially, I thought that all the different study sites use the same equipment. If they are using different equipment, the sensitivity will be so different. And looking at antibody tests, there are some platforms that will only detect IgM. There are some that will only detect IgG. There are some that will detect IgA. And there are some serological tests that we call them total antibody tests. QIAGEN had a good one, which we helped validate here at Stanford. It's a total antibody test. So you cannot be comparing, a serological test that measures all IgM, IgG, and IgA with one that measures only IgG, right? So from the laboratory tool itself, when designing such studies, if the platform is not the same, then you can't really, compare those results, satisfactorily. That's going to be a limitation in the study. I do understand that each country has its own system, but it really varies. For example, our in-house ELISA test here, when we implemented another one in Hawaii, it's a Luminex platform, we saw some variability in terms of the sensitivity as well. Then if you also look at Professor Leke and myself, we went back to look at samples that we had collected in Cameroon pre-pandemic, right, before COVID. And what we are seeing is that there's still a lot of cross-reactivity, right? You see those pre-pandemic samples still testing positive for COVID antibodies. And if you look at the S1, RBD, and the N protein, a lot of the cross-reactivities with the N protein. And then we moved further to do print assay to look at the ability of these samples to neutralize the actual COVID virus. Neutralization potential was not there, right? So then also RDTs, I always say we really have to be careful with RDTs. The quality of an RDT is as good as, first, the recombinant protein that is used in the RDT, and secondly, the antibody that's used on the RDT. Understand that you need both those things for an RDT to function properly. Now, if the antibody is not well purified, you're going to have a lot of cross-reactivity as well. We already know that, RDTs, especially for serological testing, already have, their own limitations. And for some RDTs, they'll either measure IgM or measure IgG, right? Some may try to measure, total antibody. So all this different variability, if you use RDTs from 2 or 3 different manufacturers, you'll get different results. But if you use the same RDT all through, the sub-Saharan African region, then you'll be able to get some kind of data that you can compare, across the different countries. So it may be difficult to actually make that comparison if the laboratory tools were not the same. And one thing too, I will always advise, when doing serological tests is, it's good to have multiple targets, right? If you have the S1, you have the RBD, and you have the NP in your ELISA platform, that is good. Because with that, you're also able to distinguish between vaccine-induced immunity and also naturally induced immunity. For example, if somebody has taken, the mRNA vaccine, you expect to find NP negative, then you expect to find S1 and RBD positive. Then you say that, hey, okay, this person is vaccine-induced immunity. I'm just saying if the investigators really want to do further studies to actually see how it goes. But then if it's a vaccine that was the whole virus, it will be difficult, right? Because if it's the whole virus, it's going to elicit immune response against all these different proteins. But that is some good work. It's the first time I'm seeing this data. The very first one I saw was from Kenya, but this data is so good. So kudos to the team. Reach out if you need any help, any collaboration. Good job, guys.
Thank you, Doctor.
Thank you. This is exciting. Dr. Karl, this is one of the reasons why we run this town hall to foster these kinds of collaboration. So please feel free to knock on Dr. Kenji's door. He would always respond, but if for some reason he doesn't respond, the town hall would go after him. He never says no to us, so we'll chase him until he gets these collaborations running. But this is exciting. Thank you so much, Dr. Kenji, for chiming in. Now we have a few questions in the chat, but before we take them, I'm just going to drop in the chat the current Cameroon health sector strategy. So this strategy is meant to cover the period 2016 to 2027. And I am also just thinking about whether our health sector strategy has got aspects of this whole pandemic preparedness incorporated within it, and how people who are primarily public health and epidemiologists could drive this agenda when some of these health sector strategies are being developed. I know that the strategy was developed in 2016 before the pandemic came, and it covers up to 2027. But is there room to try to incorporate aspects of health sector strengthening, with regards to pandemic preparedness within this strategy? And the reason I'm asking is because the pandemic came and it opened up a lot of opportunities for collaborations, for funding with regards to some of these things. And if we don't leverage these opportunities while they are still there will come a time where even the funding we would have grabbed is going to pass us by. And for those of us here who are like in policy and public health practice and EPI, are there any efforts to try to leverage this opportunity and incorporate and push this agenda into the health sector strategy? So I don't know, Karl, Bryan, or anyone else in the house might want to, comment on this. if we don't have any comments, maybe it could be an area for us to reflect on how we can drive this agenda, because we see a lot of HIV, malaria, which of course, developing these sectors could help in strengthening the pandemic preparedness in one way or the other through availability of instruments and through capacity building. But pandemic preparedness, I think now COVID has opened our eyes for the need for a targeted intervention towards this sector. Yes, Dr. Muno, I see your hand is up.
Yeah, my next question really is to Bryan, and the next is to Karl. It's really a good question I want to ask them. How prepared, after doing this presentation and after Bryan in the CDC, how prepared does he think the CDC is for a next pandemic? And how prepared is the WHO as an organization for the next pandemic? Is the WHO actually taking the forefront? Alison prepared some wonderful documents WHO has. Does WHO themselves, are they capable to convert this bureaucratic organization into a practical organization that can stand at the forefront of preventing pandemics and making decisions that are going to be right? I was one of the biggest critics of WHO just because maybe my background is involved in multiple things, and I thought all their decisions from day one, I was very open, was wrong. And I thought this was a pandemic. The first day I heard about it and I saw it and I saw things that were happening, and I just saw people who were taking care and who were in charge of healthcare making decisions that I thought, yeah, truly they did not understand everything that was going on. But is WHO, even just with the monkeypox, I'm just asking Bryan, I don't want him to be stay political, but in the monkeypox itself, has WHO put itself at the forefront right now? Now that we have just 142 cases, are they at the forefront of trying to bring about collaboration between the European countries and North America, trying to see how we can trace this and understand where it's coming from? Have they learned a lesson from this pandemic? Going to Africa now, back home, do we still think this is a problem that is happening in the South? Do we think this is a problem that will not happen in Cameroon? How prepared are we at this moment from what we have learned from COVID, going forward to other new emerging pandemics that are going to happen? They are going to happen now. Once every 1 or 2 years, we'll have something new coming up, especially with the level of mobility that is occurring between countries. We are no longer isolated countries in themselves. We move a lot. The world is really a global village. So how prepared? This is to Bryan, CDC, the NIH, the WHO, and to Karl locally, how prepared are we? At the level of the epicenter, advising the government in Cameroon, working with them, how prepared are we to tackle the future pandemics coming forward? What have you learned from what you guys really did in COVID? And I want to applaud you guys once more. You guys are doing wonderful things.
Maybe Bryan, you might want to go first. Bryan, I'm not sure if you're speaking, but we can't hear you.
Yeah, it looks like I have issues with my audio. Can you hear me?
Yes, we can hear you now.
Oh, awesome. Yeah, I said I'd love to hear Dr. Yap's thoughts on this question as well. I think overall, as a global community, we just haven't had the really best response overall, and there is really a great need for collaboration. There's a great need for capacity building. There's a great need to make and develop and build better tools. I was really very impressed with the work that the team in the UK did with the recovery trial and established this platform for dexamethasone. And we're able to discover very early how much of a role that had in decreasing mortality and things like that. So we definitely need that. And the second thing that I think is really crucial is building, Bill Gates wrote a book, I think he published a book just a few weeks ago called How Do We Prevent the Next Pandemic? And I really highly recommend the book. book as well. And in the book, he talked about the importance of building some kind of applied epidemiologists or a team of applied epidemiology. The CDC has that fellowship called the Epidemic Intelligence Service that basically really trains applied epidemiologists and sends them out in the field to investigate disease outbreaks and things like that. So I think if WHO and have just a similar framework to investigate these kinds of disease outbreaks as well, I think that would be very, very helpful. I can only speak for the United States. I can only speak for the monkeypox outbreaks that's currently in the US. We currently only have 2 cases. I can talk about the outbreak in Spain and Portugal, for instance, and the UK. I know WHO is involved in that specific response, but in the United States, there's been 1 case in monkeypox in New York City, and there's one case in Massachusetts as well. The case in Massachusetts has been confirmed by PCR and sequencing as well by the CDC. So very clear, we do know about those already. But I think it's very important to have this communication, cross communication between agencies, and the CDC being, for instance, being able to work with the World Health Organization, being able to work with local health governments themselves, and getting as much data and getting as much information would be really crucial. The third thing I think is very important is for us to improve our disease surveillance mechanisms, and we need to build how we collect data and how this data is being stored and how this data is being shared and how this data is being analyzed, and making this process real time is really going to be really crucial. And for this to happen, we really need to have cross collaboration between stakeholders and institutions and partners and things like that. We also need to strengthen health systems. I think those are some of the key lessons that we've probably gathered or we've probably learned throughout this pandemic and things like that. So it's very, I think this gave us a really huge opportunity to, the COVID-19 pandemic in particular gave us a really huge opportunity to look back at ourselves and look at our failures and the things that works and the things that don't work, and see what areas we can improve and really build capacity on, and the areas where we still need to grow in. And yeah, I think those are the thoughts I wanted to share. I really was gonna call Dr. Kenji as well, because he's been very, very involved in, Stanford University was the very first institution in the United States that produced the first PCR test when, one of the first PCR tests when the COVID-19 pandemic just started. And I think it's really critical, the work that he's doing. I know he leads the laboratory efforts there at Stanford. So, and really how do you do that? How do you build that? How do you build something from scratch? How do you build a diagnostic PCR for scratch that can be utilized nationwide and things like that? And I think there's a lot of lessons that we can learn from that, even sequencing, right? How do we build primer sets that really help us, amplicon-based approaches that really help us to amplify a segment of the DNA, of the RNA in such a way that we can understand the characteristics of, a new disease threat and things like that. So I think that there's just a lot, it's a lot of talent in the town hall, and I want to hear Dr. Kenji's thoughts. I would love to hear Dr. Yap's thoughts as well on this whole conversations around pandemic preparedness and what lessons we've learned, and how we can build back better. Thanks.
Yeah, thanks, Bryan. I think probably I'll just go first. One of the things we've really learned in the lab is for us to stay ahead of the game. I'm just waiting once the sequence has been published for the current monkeypox that is circulating in the US. We're just going to start designing primers, right? So you have to stay ahead of it. There's no case reported yet around here in California, but just designing those primers, having the assay ready, optimizing it, doing your analytical validation. You don't need the actual virus, right? I mean, before for COVID, what we did was we just used single-strand DNA. We did a synthetic version of single-strand DNA. and we're able to do all our limit of detection and everything. Then we used it now to spike clinical samples. So there are approaches that you can use, right, without having the actual clinical sample. So I think that will always, be the approach. Let's be ahead of the game. Let's build capacity. I'm so happy that now in Cameroon and other African countries, there's a lot of PCR instruments, right? Let's make use of those instruments. But most importantly, I think it's high time we stop relying on the West for assays, right? And all those things. We need to build capacity locally in Cameroon and in Africa where we can design our own assays. I was so happy where I saw in one of the publications that the ELISA was in-house. That's the way we have to go. Because one thing, when you keep relying on the West can only send you something, at times I say they send us the crumbs, right? It's not in every instance, but they always say charity begins at home, right? If Roche is running out of reagents, though they have that obligation where they will probably want to supply labs in Germany and US first before supplying labs in Cameroon, and the time that it takes to ship and all those things. So designing those tests, building that capacity is very important. One lesson that we've also really learned in the lab is clinical labs were not equipped to deal with pandemics of this scale, right? So you really want to expand, but you don't have space to even expand. We faced that challenge here, right? We wanted to do more tests, but where we buy these equipments, where do we keep them? So we just came up with a strategy of using our freezer room. So we had to convert our freezer room into a lab to be able to do this testing. So this is another lesson that we've learned, right? Being able to know that, hey, we need more space, to be able to do this testing. And another lesson we've learned is that you must not have the very expensive instrument from Illumina and all those things to be able to do genomic surveillance. The strategy we are using now, we don't sequence every sample as we used to do before, right? When we started before, all positive samples we were sequencing. Once, these sequences are published, you can design, a multiplex PCR that can target BA1, BA2, BA2.2, and any kind of thing. Then you now rely on that multiplex PCR, and you only sequence those samples that are negative by that multiplex PCR. For now, we are no longer testing for Delta, right? We are no longer testing for Alpha. Those are gone. So we now have an assay that we are looking for BA1 and BA2. Almost everything now is BA2, right? Now, if another variant pops up, we just redesign the primer and we add it to that multiplex assay. So only samples that are negative using that regular PCR assay with the specific alleles are now proceeded to do sequencing. So it has really saved us a lot of costs for sequencing. It has saved us almost 70% of our sequencing costs. So that's one thing that we've learned as well. And I'm glad that some labs had contacted me, and some of them already using this platform in terms of genomic surveillance. So we can still do more with the less that we have. With the PCR instruments that we have in Cameroon, we can still do good genomic surveillance.
Thank you, Dr. Kenchi. Christelle, à vous.
Thank you very much. Dr. Fay, you wanted to say something?
Yeah, they have not finished my second part of my question.
Yeah, sorry. Yes, go ahead, please.
So I will talk about how prepared do I think Cameroon is for the next pandemic. And I believe there are 4 cardinal points which makes a country committed for a pandemic. First thing is commitment. It's commitment of that nation or of that agency towards the disease preparedness. And this comes about from coordination of all the major stakeholders that are involved, and creation of active services that can act in such situations. We can see in Cameroon, there was a creation and an immediate activation of the Public Health Emergency Operations Center, which has done a lot of work during the COVID-19 pandemic. And now they are doing a lot of work with the cholera, the present cholera outbreak in the country. And then the next thing I will talk about is action. Action, like we should be ready to commit, but we should be ready to take the action. And where are the main action points? We should take action, especially at the level of strengthening our health systems. How do we strengthen the health systems? In improving the amount of finances or the amount of money we put into our health systems, improving our laboratory services. And we can see with Cameroon, with the pandemic, we moved from just about 2 laboratories that could could be used for COVID-19 testing to about 15 nationwide. And that was quite a great improvement in our laboratory services. Now, we also look at the quality of data. Yes, we should do surveillance, we should do research, but the quality of data which we have should be reliable, should be informative, can be used to make decisions that can help us to approach a pandemic or future outbreaks. And then we should also look at, especially in COVID-19, we see vaccine supply, vaccine research. And yes, we don't have that capacity to produce our own vaccines. Yes, we should. I think that is one of our plans in the future. I think young scientists here will be thinking about that and how we can do that for our nation in the future, in the near future. But we should think about also developing these cold chains, so keeping these vaccines, so supplying these vaccines and making them readily available for everyone. And if we see Cameroon has moved up to 1.8 million, that is small, but I will applaud the strategies that were put into place to improve these numbers, because before, like 6 months ago, we were just at about 500 to 600,000 people vaccinated. But we actually developed this strategy whereby we did community vaccination, where we moved down to the population and say, look, here's the vaccine. This is what the vaccine does. It prevents severe forms of the disease. Now, we have brought the vaccines to you. And that's how we have the people actually is using strategies that have been used for other diseases, like during the national vaccination campaign, so polio, where the community health workers go down to the population to actually get more people vaccinated rather than calling them to the hospitals. And that's some strategy that has been put in place for COVID-19 vaccination to improve the vaccination rates in Cameroon. And these are some lessons which the West could learn from Africa in terms of pandemic preparedness. And the third point, which I spoke about commitment, action, collaboration. We should be open to collaborate with other agencies and other countries. There should be that regional collaboration. And I would like to applaud the Africa CDC for the coordination they have been doing so far with COVID-19 in Africa, in the Africa region. And then we have the last part is the learning. What do we learn from these pandemics or from the past pandemic? How do the lessons from this past pandemic influence our population for the next? Yes, thank you.
Many thanks. Thank you very much, Dr. Fai, Dr. Kenji, for your insight. I think in addition to the lab preparedness and the experience sharing from Dr. Fai, I may add also the communication, the effective communication, because I feel like also Dr. Foma said that it's in this platform now that I'm able to get a lot of knowledge about what is ongoing. So it will be good to have also effective communication, and yeah, should find a better way. Please, Professor Yap, you have the floor.
Thank you very much. It was quite impressive to listen to all the different speakers and panelists. And I was in a conference 2 days ago in Barcelona, and they were reminding me that Cameroon is the country with the highest number of well-educated people. And while listening at the people around in the panel, and also from the quality of the question, I can really confirm that. Saying that, I also saw a comment saying that one of the challenges that we have, I think it was from Kwan, is that there is no action. And the actual thing is there is a lot of action, a lot of things has been done. Dr. Fai have mentioned some of them. We moved from one lab able to do PCR for COVID at a time where COVID were coming in Cameroon to 45, which is huge at the level of country like Cameroon when you compare to Ivory Coast, to Niger, and to many other countries. We now have 4 next generation sequencing, and I was quite interesting when Kenji was presenting the algorithm on how they actually screen the sample, and then they sequence only those that are negative. And we've implemented the same strategy in Cameroon. which make us save a lot of money and also give us a bit more time to have our platform very operational. But what we are lacking is the ability to tell our stories. And to tell our stories mean by publishing our data. What Fai have presented, none of you have actually seen those data because we have not yet had the time to publish them. Next week, the Ministry of Health will organize a workshop on scientific communication. And I'm glad that Bryan will be one of the coaches to support some of our people who have led the response, but who unfortunately lack the quality for scientific writing. So I also call upon those who are around the call today. If some of them have time and would like to get involved in what is happening in Cameroon and would like to coach some of the people on scientific writing, they can contact me or you or actually Fai so that we can see how they can support. On the side of preparedness, we were actually very well prepared before the COVID. Why? Because we were prepared for Ebola. You remember that we have all those Ebola outbreak in West Africa and then in DRC, which is nearby. And thanks to Ebola, we implement the Public Health Emergencies Operating Center. And that Cameroon was actually one of the first ones to have a whole building dedicated to respond to pandemics, thanks to the CDC Atlanta, who helped to build that building. And the building was just there. And it's when COVID-19 started that we actually start using that building and implementing what we call the incident management system. And that IMS, though it was used before for HIV, for maternal mortality, was really strengthened and really found its position within the preparedness and the response to outbreak in our country. Now it's being used for cholera, it's being used for yellow fever, and even monkeypox, because we did have monkeypox months ago, and we managed to respond to that outbreak here in the country. Maybe the last thing I would say, what strategy can we implement to improve the response? And I will touch a bit on the issue of vaccine. You all recall what Gandhi was saying. He was saying that whatever you do for me, without me, is against me, which lead to the community engagement. How do we engage community on implementing strategy that has to be local? As Fai ends his talk by saying that there is no one-fit-all solution. It does mean that it's not because vaccination is working in the US, in Europe, in China, that it has to work the same way in Africa. And what we get from all those seroprevalence surveys, though we have different results, because the seroprevalence survey, it's a picture which is done at a very point of time. So you cannot compare seroprevalence survey result if they are done at different time point in different countries. So it's important to have that in mind. But what we get is that the Africa has been exposed to COVID. Whether we're talking about 5, 10% or 48%, that's a large number of people, but we have not seen so much people dying. That is a message. Which message it is that Africa most likely is the continent that has managed in one way or the other to reach its own herd immunity, at least in the big cities, because something that also we should highlight is that the study in Cameroon was done in the 10 region, while most of the other was run in big cities. So when we manage to have the herd immunity in some of those big cities, it's because of one of the reasons, actually not the only one, one of the reasons is because of the young age of the population, that is one, but also because of the characteristic of the population. If you take a country like Niger, in 2 years of pandemic, there were like 300 deaths. If you take a country like Uganda, we were around more than 3,000. But the two countries had the same mean age. But the main difference is the population. If you look at the burden of NCD, non-communicable disease, hypertension, and cardiovascular disease, they are much higher in Uganda. Therefore, this can explain why they had a more important number of people dying. That's why it's critical for each country based on the epidemiology, based on what they have seen, to see which population are really in need of vaccination. And we should put all the effort on those populations and rely on the data that was present. If we need 2 boosters, 3 boosters for those populations, let's make those available. Let's make sure that the communication that we use also, it's not a mass communication where we say everyone should get vaccinated. We should actually focus on sending the right message to those who are the most at risk, because we have those information and we have those data. So we are actually advocating for local solution where the community is really, really part of the solution. Those are the few comments that I wanted to add. Thank you.
Wow. Thank you so much, Professor Yap, for your contribution. Very insight and very interesting from the field, from your experience, both national and internationally. And then thank you so much for being with us today and sharing your experience as well. So I see the discussion are very dense, and then I want to go to the chat, but I see as well we have Dr. Nicole who is around and she wants to contribute. Please, can you go ahead before we dive in the chat to respond to the few questions that were raised in the chat?
Okay, hi everyone. Thank you for giving me the floor. It's really an interesting chat on preparedness. So I just felt I should intervene because I'm actually working with the WHO on preparedness and response to health emergencies. So just to let you know how we support countries to get prepared. So the WHO supports countries technically, financially, and with human resource. I wouldn't say it's really perfect, but we do quite a lot. So we support many pillars of a response, like coordination. We encourage countries to have action plans for health security, and I think Cameroon is doing well on that. Beyond the plans, we encourage countries to strengthen their laboratory capacities, case management, like we sponsor reagents, we furnish laboratories. Regarding case management, we really contribute to strengthening the health system by like in the, I'll give practical examples. In the Northwest and the Southwest, we capacitated reanimation centers and they are furnished. So now if we have another pandemic, I think severe cases will be managed properly, provided there are human resources. So I was just going to say we do a lot. We strengthen most of the pillars like the labs, case management, logistic capacity, reinforcing human resources technically. But the weak part is about involving people more locally, like what Professor Yap said. You know, when it comes to vaccines, we don't have capacity to do our own vaccines and stuff like that. And this contributes to hesitancy. And I wouldn't say we are quite prepared when it comes to such things like vaccines and drugs, because we obviously don't engage very much into research concerning therapeutics. So that is how the WHO contributes to preparedness and to response. I just wanted to mention that a lot is being done, but still much has to be done. And also we encourage countries to do simulation exercise and also reviews of previous responses, like Cameroon did an interaction review of the response to the COVID-19 pandemic, and they came up with some lessons learned. That is one way to prepare, to know what was done. Was it done well? What can we improve on? And what have we learned from? Another way is to do simulation exercises, but I wouldn't say we are doing a lot of simulation exercises to see how prepared we are for the next pandemic. So yes, a lot is being done, but much still has to be done. Thank you very much for coming up with such an interesting topic. Congrats.
Christelle, est-ce que je peux poser une question avant? Just a little, just not that I want to monopolize, but I want to ask before Dr. Yap leaves and and Nicole. I want to ask, so, you know, South Africa has gotten to a point where they are developing a vaccine, and nobody has actually requested or put in place any form of demand for this vaccine, including African countries. Do you think that going forward, we are also part of the problem in Africa to encourage ourselves, to capacitate ourselves? We want to make companies to produce drugs, have capacity to build vaccines, but do we trust each other enough? Do we have intercooperation in Africa enough that as a people, we can actually stand for ourselves and be able to fight a pandemic without the help of those who are in the West? It's just a reflection of, or those in the East. Are we able to do that? How can we trust each other and say, okay, we can trust science that is coming from Africa enough that if Cameroon one day makes a drug or makes a vaccine, other countries in Africa will be able to buy it or will be able to demand for it?
Thank you, Chairman. So maybe before Dr. Fai and Dr. Bryan respond, let me add two questions from the chat going in the same line. So one was from Dr. Wingo to know about what is the use of genomic surveillance in the Cameroonian context, especially as we are going towards preparedness in a timely manner for future epidemics. And then Boris also was asking which approach is best to use in our context to convince people for the vaccine hesitancy? What can we do best? It's true that Dr. Nicole thought about first, because one of the key points was that it was a vaccine coming from outside, so less trust. So yeah, which approach do you think can be very productive to convince locally people to get vaccinated? You have the floor. Bryan?
Yeah, sure. Really, yeah, I think the questions Dr. Mono maybe ask more directly directed towards Dr. Karl and maybe Dr. Yap. But I just on the question around genomics, I think just wanted to quickly share my screen again for one quick second to share some of, let me see. Can you all see my screen?
Yes, we can.
Oh, awesome. Yeah, so awesome. Yeah, this is, again, I've been working with GISAID. GISAID is the global initiative for sharing all influenza data. Initially, this platform was built for just for flu, essentially. But when the COVID-19 pandemic started, it initially started getting more and more data for COVID-19 and sharing that on a global, on a national platform. And so what we really have here is really most of the genomic surveillance systems. And this is something that myself is hosted within the Africa CDC, but myself and some members of the team right there, we've been building and maintaining this to see how the COVID-19 pandemic has been evolving from a genomic point of view, how that has been evolving in Africa. So this is a specific build for Africa, for Cameroon more specifically, and how the different sequence samples from Cameroon has been, what the evolutionary dynamics are over time. So you can see how we started with the 28 clade and the Delta clade, and how that has really evolved over time, and eventually were overtaken by the Omicron 21K and 21M, etc., and things like that. So it's really been a depiction of what the evolutionary dynamics are. And what we've actually done is we've been able to build a similar system for all the countries in the Central African region. So you can see the individual bills for all the countries in the Central African region. You can see the individual bills for all the countries in the East African region, the Northern African region, the Southern African region, and the Western African region. And what specifically we are able to see are those specific mutations and specific mutations that might pose a specific problem for immune evasion, for example, and things like that. So we know about the L452R mutation that was very notorious during the Delta wave because it was known to be associated with some increased transmissibility and things like that. So we are able to have a system that enables us to pinpoint and to be able to track very specific mutations at a very granular level. And using different kinds of epidemiological models and multinomial analysis, we're able to predict and tell the trajectory of very specific lineages and things like that. So this platform called NextTrend really has this, again, on the left panel here, you have really multiple options. You can interact with the genome, specific genomes as you want. You can see what the logistic growth of specific lineages are. You can predict and tell what's going to happen and things like that. So that's the kind of system we have. So Dr. Wiringo, to answer your question more specifically, yes, the genomics data is very useful, can be very important in terms of, can give us an idea, but it's very important to also recognize that the epidemiological context that underpins those individual cases is also very important. Directionality cannot be inferred from a phylogenetic tree alone. The epidemiological context in which those individual cases are being based is also extremely crucial for any inferences about their dynamics. This is a very old phylogenetic tree. I think I built this several months ago, but they really trying to see what the dynamics were for the different African regions. And again, I might have to update this because I haven't looked at this in a few months, but really was trying to see what the differences are for the different regions. So the Central African region, the center region, the Northwest, the Southwest, the East region, and seeing how those different, if we are seeing any specific changes or specific representations or specific mutations or specific genetic diversity in different regions and things like that. So I think that's one of the things that we've been able to do per se, and really building on that system. In the United States, we're doing things a little bit differently now because people are not testing anymore. So our emphasis has shifted from really individual case, sequencing whole genomes to wastewater surveillance. And I think wastewater signaling or wastewater surveillance represents a very huge potential for public health, because from wastewater samples, you can really have a very good idea of what's happening at a community level. And the good thing about wastewater samples is it's not really controlled by whether you choose to get tested or not. You can tell a lot just by looking at, just wastewater samples. And not only COVID-19, but also things like antimicrobial resistant genes and gonorrhea and chlamydia and even, opioids and things like that. So it can really give you a really good idea of what's happening in a specific community. And I'm really excited about the potential of wastewater surveillance and how that can be useful at a granular level for disease predictions and things like that. So that's how I'm thinking about it. But in the African context itself, there are not many countries that do have those kinds of sewage treatment plants. So for Cameroon, for instance, I'm not very aware of how that's, if we do have sewage treatment plants and how those might be connected between cities and things like that. But I think that represents a very useful proxy for estimating where we are and what stage we are and what we could do for the future. So yeah, those are my thoughts about this, Dr. Ringo.
Thank you, Bryan. Thank you so much. We see the enthusiasm, the passion you have for genomic surveillance in your thought and explanation. Dr. Fai, do you want to comment on the previous question?
No, I will not really talk about the genomic surveillance, but I would try to answer Dr. Foma's question, and maybe Professor Yap could say more if he's still around. So earlier this year, the chief of the Africa CDC, Dr. John Kingasong, actually told countries that we will not more be receiving vaccines for COVID-19 for now, maybe until later in the third or fourth quarter of the year. Why? Because we believe these vaccines that are now available, they have, first of all, short shelf life. They expire on the shelf. And the main problem is not more availability of the vaccines, but actually the cold chain, how to get the vaccines to these populations, and also how to beat vaccine hesitancy, which is the real problem. At this moment, it's not more about availability of the vaccines, but about how do we get these people to take the vaccines that are available. And I think the South African plans to create their initiative to actually manufacture their own vaccine for Africa, like the solution for Africa by Africa, is quite great, but I believe it's coming at a really bad time where Africa is not more looking at at availability of the vaccines, but at how can we fight vaccine hesitancy? How can we make sure that these vaccines that are ordered don't get expired in the main offices in Yaoundé, in Abidjan, in Lumumbashi, and all of that. So I believe solutions for Africa by Africa are what we are going for, and what we have to encourage. And I think eventually, maybe towards the third, fourth quarter of the year, after all these vaccine hesitancy studies have been done and probable solutions have been put into place, I think vaccines should be ordered, and I believe African vaccines will be ordered by African countries.
Thank you. Yes, thank you so much. Yeah, please go ahead.
If you yes, just to add some few points, but only to say that I'm not alone. I'm with my boy, so if you get hear from him in the background, don't mind. So I was saying, I agree with what Fai mentioned, on the sense that the vaccine production in Africa was a critical decision made, and we really appreciate the work of John Kengasong at Africa CDC, and I think that's also one of the reasons why he's not going to PEPFAR. But unfortunately, it's also coming at a time where we have plenty, as Fai was mentioned, plenty doses. So are we going to pay for some vaccine, even if they're coming from Africa, while we don't need them? I think there is no country who will do that. And I even recall a discussion that we have with the Minister of Health here in Cameroon, who was requesting us to quickly implement a seroprevalence survey, another one, so that we can know where we stand and decide whether we should say yes to a loan from the World Bank to buy more vaccines. So we are in that situation. But there is always a silver lining. The silver lining is that there has been a technology transfer. You might know that 98% of the vaccine used in Africa are not produced in Africa. So maybe they will miss some money in the COVID vaccine, and we hope that we'll find some mechanism to support them. But now that the technology is in the continent, we should see how to use it for malaria, for diarrheal disease, for many other diseases that are in the continent for good, for a long time. So that's also how we can think about that investment, because it was looked from a political and, of course, financial point of view by the corporate, but not from an epidemiological point of view, because we also know that those viruses, they come, they go, and at some point, it's not definitely, at least for those ones, something that you can invest for good. So I really think that the way forward is the technology that is already in the continent. And there was one question about what should we do differently to convince the population to get the vaccine. I think it's not, according to me, the way to put the question. The question is, who actually needs the vaccine? And once we have responded to that question based on the seroprevalence survey, based on the epidemiological data, we know the people who are making severe form of the disease. We know the people who are dying. They are the elders, unfortunately, and also those who are having hypertension or diabetes. So the vaccine that we have for now prevent the severe form. They don't stop the transmission 100%. So when we'll have the vaccine that will stop the transmission, then we'll push for everyone to get the vaccine. But for now, every country, every region should really define who are those who are really in need and implement all the community engagement strategy, the door-to-door strategy, what we also try to implement during the African Cup of Nations, where if you want to go to attend the game, you need the test and the vaccine. It didn't work that much, but still we managed to vaccinate 200,000 people around that period. So yes, we need to convince, but we need to convince those who are the most at risk and those who really need that particular type of vaccine. Thank you.
Merci, merci beaucoup, merci infiniment, Prof. Yap. Time has passed. We have been discussing a very interesting topic. We used to be here for 2 hours, but we are already 2 hours and a half. So we need to start rounding up. But before we round up, I want to raise one question in the chat from Nancy. I think that this will be the last one. We are very sorry to take more questions, but we need to round up for this session. It's a very interesting session. So Nancy wished to know how can this platform, the Townhall, contribute to quality education for healthcare professionals and public health experts here in the country. I guess this is an experience sharing from each one in the panel. And also, she thinks, I hope it's a she, so with the experience from the US, what could be the suggestion in order to strengthen the public health system here, mostly based on prevention as for future epidemics? Please feel free to contribute, open your mic and give your thought on this question. Thank you.
I wish to start because I think I will be leaving soon.
Please,
so
thank you.
I really thank Bryan because he has been quite patient with me and with us on his will to support what we are doing in the country. And I think something you really need to get, though it's very paradoxical, is yes, we need a lot of help. We do need. But at the same time, people who are working here are so busy that sometimes they don't appreciate and they don't find the time to get the help we need. And one simple way is, as I was mentioning, is next week while we'll have the scientific writing workshop, we'll have some coaches. And Bryan will be one of the coaches to work with people working on the genomic surveillance. We can share the topic that will be written on in your platform. And if some of you are interested, they can also start coaching some people or some team back home. That's one way to support, but also a great way to know what is happening and to build some relationship. I know that quite a number of you are willing to know what is happening, even to come back here. I think that's one way that we can open the door. So I will be happy if we have some few of you who will be interested. Thank you.
Merci beaucoup. Alison, maybe you want to contribute, you want to give your thought. How can the Townhall be helpful to healthcare professionals and experts here back home?
Esther, I was about to put the chairman on the hot seat on that one because I was just thinking that the chairman needs to be on the hot seat around that particular question, so that he can maybe shine light on the best way forward with that one.
Okay, thank you, Alison. I want to say, I think, Nicole, this is our first time. We are a platform that we do already do that. We are not a platform for the diaspora. We are a platform that we are bringing together those who are back home in Cameroon and in Africa to have a discussion with those in the diaspora, health professionals. We're learning from each other, meaning what? We are transferring knowledge. I'm one of those, I studied back home and I studied here, and I know what I bring into the table when I came here to the US. I brought a lot of value, added value, which I actually do appreciate that I do bring that value. And I think nurses, physicians, scientists, epidemiologists have different experiences in different places that they do work. What I did in community medicine back in, let's say, in Tinka, in somewhere in Mancon, is different from the experience I would do here in New York City. And those who live here will not have the same experience going back home, especially if you want to go help. And as I would always say, we are coming into a platform to learn from each other. We try as much as possible to get speakers who are both in the diaspora and those who are at home, so that those who are in the diaspora can learn from those at home, and those who are at home can also learn experiences, and we can share experiences together. So one thing I want to tell you is going forward, and what we have done in the past 1 and 2.5 years that this platform has been existing, I know some people are discovering it for the first time, is to try as much as possible to collaborate with each other, learn from each other, and not come in as someone who is coming to teach the other person. No, we're really coming to learn. I've been fascinated from day one when I saw the first COVID patient. I was an internist here in New York City at the time. Saw the first, I was specializing in oncology, but I was an internist. Saw the first COVID patient, and I remember I did medicine biology back in Cameroon. I was a medicine biologist. But I remember that in that same environment where I found myself, I had one of the most added value in my hospital, because I called it a pandemic before everyone did. I had experience with Ebola back in Cameroon when we're preparing for the Ebola pandemic. I called out the administration who were not ready for what was coming. So that experience did not come from the US, it came from Cameroon. It came from my time at Central Pasteur. It came from my time rotating in Cameroon and seeing different things that people here had not seen. So I want to always put it in the other sense is we need to teach each other. We need to learn to see where we can add value to one another. And this platform has been doing that. And I know there have been others in this platform like Kenji who have been ready to try to get us quality projects. And Allison, who have been working on vaccine hesitancy, which is a whole thing with Professor White, Dr. Allison and Prof. Allison, I'm almost forgetting Prof's name. So Professor Wisonge have been doing for a while. And we do have a lot of other people who have been here into the platform, and they have worked on multiple projects. Allison had a project where we were actually documenting all the publications that were occurring surrounding COVID. We do have those files that we share. And everyone who had published anything concerning COVID who is a Cameroonian or affiliated to Cameroon, and we could share in a platform. So we have also, I'm an oncologist in practice. We have teaching sessions where we're going to collaborate with residents back home in Cameroon, where we're going to talk about different cancers and how to manage cancers overall, learn from each other's experience, what is the best way to go forward. I'm working with that with one of my colleagues who is a surgeon in Cameroon, Dr. Tim Fabrice. So there's so many projects that are getting their origin from the town hall, and we are open to ideas. And I wanted to tell Professor Yap, I've heard a lot about him from Bryan, that he's welcomed here at any time. This is a bilingual platform, though today was a lot of English. So it's a bilingual platform, and we're trying as much as possible. This started about almost 3 years now out of COVID, one thing we're interested in COVID. I did work with the Northwest and Southwest, and also Nicole has been logging in here several times, and I'm encouraging her if she has a topic that she wants to talk to us about, where she's very welcome. I did volunteer in the Northwest and Southwest, myself and Dr. Brunhilde. We used to attend their every Monday WHO controlled pandemic programs where we were helping in managing critical cases. And I think through that platform, we had to teach and educate each other what was going on, and also educate on how to use a BPAP machine, a BiPAP machine, a CPAP machine, how to even do safe intubations, how to take care of patients who were intubated, what kind of oxygen requirements were needed during that time, what is a known rebreather mask, how do you use it? I trained also in the Faculty of Medicine. I never used a known rebreather, but I found it, but it was time where we transferred knowledge and we also learned from them. So this platform is really one of those platforms where you can create subgroups, you can have organizations that you guys can actually have working sessions together, and we applaud all of that. So I want to use this, Alison, before you go, to thank everyone. If you know of someone who is doing anything which we can learn from, please tell them this is the right platform. They should contact anyone who is here, and we're going to give them a platform to talk to us and for us to learn. We can interact. We call it a town hall because it's not just presentation. It's more of presentation, sharing ideas, and discussing. So I hope I did answer some of those questions. There are projects going forward, and in the epidemiological field, if there's someone who has a project that they think we can move forward in Cameroon and train others, we are going to be willing to collaborate with them. So thank you.
Thank you so much, Chairman. Christelle, vraiment, ça a été une session très intéressante. Et je crois que, bon, il faut qu'on s'apprête à rentrer chez nous maintenant. Sinon, les gens vont dire comment vous ne voulez pas finir.
Un samedi soir.
So I want to use this opportunity to thank Dr. Fai and Dr. Tegomoh for these amazing presentations and this great session. Thank you so much for all the knowledge, all the resources, and kudos to you for the great work you're doing individually and with your respective teams at the Africa CDC, at the US CDC, at the epicenter, and all the support you're bringing to policymakers. We really applaud your efforts, and we hope that you continue to shine the light for those who are maybe lagging to take up the examples that you're setting. We've come to the end of this session. Christelle, ça a été un grand plaisir d'être avec toi ce soir pour cette session. Je ne sais pas si tu as des derniers mots pour nos téléspectateurs.
Plaisir partagé, Alison. Merci à tout le monde. Grand merci.
Okay, and on this note, we're going to end this town hall. And please do not forget, right after this, we have the parking lot, which is a more informal session just for networking and exchanging of contacts and creation of collaborations. It is not recorded, it is not live streamed, and we usually have some nice refreshments. There's fufu corn on the corner with kati and some palm wine for those of you who drink palm wine. So please hang in there with us. On this note, I wish you all a great weekend and a great week ahead. I wish you good health and all the best for the rest of this week.